Good afternoon, everyone, and welcome to yet another event in our public policy seminar series. Today we have the very distinct pleasure and honor of welcoming to campus the current Insurance Commissioner for California, David Jones. But before I bring him up, I'd like to first go over the format for this seminar. We'll reserve the first 45 minutes or so of the time period that we have for the Commissioner's presentation and remarks, and then we'll have some time in the end for Q&A. So unless you have a clarificatory question, you might hold it off until the end. Okay. Now let me tell you a little bit about our speaker, although he doesn't really need much of an introduction. He's been California's Insurance Commissioner since 2014, when he was, well, no, you've been Commissioner since 2010, but you were re-elected in 2014. He leads the California Department of Insurance, or CDI, which is the largest consumer protection agency in the state, which regulates $123 billion insurance industry. That's a staggeringly large industry. And as we were talking over lunch, the insurance sector in California actually sets the agenda for the nation. And many of the things that we do in the insurance sector are emulated not just by other states later on, but by the federal government. And so this is a very important industry, and Commissioner Jones has the task of regulating that large industry. Prior to becoming Commissioner, he served in the California State Assembly from 2004 through 2010, where he chaired the Assembly Health Committee, the Assembly Judiciary Committee, and the Budget Subcommittee on Health and Human Services. Commissioner Jones began his career as a legal aid attorney, providing free legal assistance to the poor with legal services of Northern California from 1988 to 1995. He served in the Clinton administration for 3 years as Special Assistant and Counsel to U.S. Attorney General Darren Reno, and he served on the Sacramento City Council from 1999 to 2004. Commissioner Jones graduated with honors from DePauw University, then went on to getting a joint degree from Harvard Law School and Harvard's Kennedy School of Government. So he actually holds a master's in public administration, which is a source of great interest and admiration for us, because we are just launching a new Masters in Public Policy program here at UCR, as you know. He and his wife, Kim Flores, have 2 children, Isabel and William, and they live in Sacramento. It's a pleasure to have Commissioner Jones here today with us.
Thank you, Dean, for that very kind introduction. I'm instructed to turn this on. So hopefully I'm live now. Can everyone hear me? Wonderful. How many of you are undergraduate students, just by a show of hands? Fantastic. Any graduate students in the room too? All right. Well, I'm delighted to be here with you this afternoon. It's a great treat to get a chance to spend some time with you. And as the Dean pointed out, I have a very strong and high regard for public policy students and public policy schools, both at the undergraduate and the graduate level. I have a whole speech I give. I shared that with some of the students earlier about going to policy school instead of law school, and why it's better to go to policy school than law school. I won't give that speech now, but I'm happy to share that with you at the Q&A if you'd like. Most significantly for me, when I went to public policy school, I met my life partner and wife. And even better, she was from California and a UC grad. And so I like to say that this family, of which I'm a member, is a product of public policy school. And so there are good things that can happen to you as public policy students. And I'm also delighted, of course, that UCR is launching a new graduate school as well in the fall. And I think that's tremendously exciting. And the Dean has invited me to serve on the advisory board. And I'm really, really honored to have a chance to do that. So first, a little bit about the California Department of Insurance. Many of you probably didn't realize you have an insurance commissioner, let alone one who is directly elected. But in California, the insurance commissioner is directly elected by the voters just as all of the other constitutional officers are. The governor, lieutenant governor, treasurer, controller, superintendent of public instruction, the attorney general, and I left someone out. Secretary of State and insurance commissioner. 8 directly elected officers. I do not report to the governor, lieutenant governor, attorney general, secretary of state, or any of those people. I report to you, the voters of California. And the voters created this as an independent, autonomous office to regulate the insurance industry because fundamentally, the voters wanted to make sure that the commissioner would represent the views of consumers and Californians in regulating a very, very powerful and economically necessary industry. So our mission is there to ensure vibrant markets where insurers keep their promises and the health and economic security of individuals, families, and businesses are protected. Our vision is insurance protection for all Californians. That has 2 facets to it. Consumer protection, consumers being businesses and individuals and families in their interactions with insurance companies, which are very powerful entities, making sure we're protecting consumers, keeping a level playing field. But also insurance protection for all Californians from the standpoint of making sure that we have active, healthy, vibrant, functioning markets that offer insurance products to meet all of Californians' needs. I have 1,300 employees, skilled civil servants to help me do this, a budget of about $245 million a year. As was pointed out a moment ago, we have some broad regulatory authority. We're a consumer protection agency fundamentally, so some of the things we've done since 2011 when I first came into office was we've saved consumers and businesses over $1.9 billion in premiums they would otherwise pay by regulating the rates of auto, home, property, and casualty insurance. Although I don't regulate all insurance rates, and I'll explain a little bit later, I don't regulate health insurance and HMO rates, so I can't save consumers money there. We have an anti-fraud function. We're a law enforcement organization. I have 300 law enforcement professionals who work for me. We investigate all sorts of insurance crimes. Since I was first installed, we've had 3,400 arrests for fraud. We've recovered $243 million for consumers in that period of time, based on complaints and what are called market conduct examinations or investigations. We get about 170,000 calls for assistance a year. Now, as the Dean pointed out, California's insurance market is the largest in the United States. 6th largest in the world. $257 billion a year in premiums. The Dean mentioned a slightly lower number. That number relates to the amount of premium I directly control. But the overall market is $257 billion a year in premiums. Major component of our California economy. Just think about it. You couldn't really function without insurance products. As a business owner and operator, as a family, as an individual. Auto insurance, home insurance, life insurance, health insurance, business liability insurance, you name it. It's all necessary to provide peace of mind, financial security, and financial relief if bad things happen. So a critically important part of our economy.
So
now,
can I,
absolutely.
This seems like such a huge amount. If you divide that by the population of California, you are getting a huge premium per capita.
Yes.
Is that because
well, a lot of that has to do, a lot of the size of the California market has to do with the size of our economy. And the lion's share of that premium is actually paid by businesses for a variety of different lines of insurance. And so because we're such a economically robust state, because we have so many employers here, because we are so big, we also have a very, very large insurance market as well. But it does mean that California is a trendsetter with regard to insurance regulation because things that we do here have a tremendous impact then across the United States. So what I wanted to spend my time talking about this afternoon, though, was healthcare reform, and specifically the Federal Act known as the Affordable Care Act, or what's also known as Obamacare. And I think it's important to first start by talking a little bit about the scope of the problem or nature of the problem that this policy was designed to try to address. First, we had 50 million individuals in the United States who were uninsured. Second, in the United States, we spend about $2.8 trillion annually on health care. Health care costs annually are equivalent to about 18% of our national gross domestic product. Now, it's important to understand how aberrant that is. In other first world industrialized countries, healthcare spending accounts for less than 10% of those other countries' GDP. So we spend collectively almost twice of our gross domestic product on healthcare and health insurance than other first world industrialized countries. The other thing to note too is that our per capita healthcare costs also greatly exceed those of other first world countries. In the United States, our healthcare costs average more than 8 countries. The average cost is just over $3,200 per person. So our per capita costs for healthcare are almost twice as much as other Western industrialized nations. Now, a significant contributor to these costs is high administrative costs. In the United States, we lead all other industrialized nations, and this is something to be proud of, in the share of national healthcare expenditures devoted to insurance administration and profit. And here's the real kicker. The percentage of the GDP that will be devoted to healthcare is anticipated to continue to rise, about 5.8% annually. Now, in the last 2 years, the rate of growth has actually not been as high as that. It's been more on the order of about 2 or 3%. Some attribute that to the recession and climbing out of the recession. Some attribute that to some of the reforms I'm going to discuss a moment ago about the Affordable Care Act. I think it's sort of a mixed bag. But even with that lower rate of increase, we could be, by 2022, spending more than 20% of our gross domestic product on healthcare. So some say it's just eating us alive. Now, what is also critically important to note is that in California, we had the highest number of uninsured of any state in the union, 7 million. So, I think the other thing to note too, before I talk about the Affordable Care Act itself, is that all of this money that we're spending isn't getting us better health outcomes. And that makes the situation even worse. In the United States, life expectancy is 78.2 years. In the other OECD or Western industrialized countries, the average life expectancy is 79.5 years. We're dead last amongst the OECD countries in infant mortality. When it comes to curable diseases, we lag behind these other countries also. In a number of other areas, despite spending more, our health outcomes are worse. So we're spending more per capita, more as a percent of our GDP, but we're not getting demonstrably better outcomes. In fact, our outcomes are worse than these other countries. And we talked as well about the number of uninsured, which has been a huge, huge problem. Now, here's something that's important to understand about the uninsured. They get care, but they get care at the worst moment for them and the worst moment for the rest of us. The uninsured typically get care in emergency rooms or emergency departments because they don't have health insurance. They have to wait until they're really, really sick, which causes them a lot of undue suffering and in some cases can result in chronic illnesses or even death. When they finally present themselves for care in an emergency room, they're presenting themselves at a place in the healthcare delivery system where it's the most expensive to treat or serve them. And guess what? Those costs get shifted to everybody else that has private commercial health insurance. So it's estimated that the average insured person pays an extra $500 per year in premium, while families are paying about $1,400 in additional premium due to the cost shifting that occurs from the uninsured. So having so many people uninsured is not only bad for them, but it's bad for everybody else as well. So let's talk about the solution that was enacted. Now, there were a whole range of possible solutions. As public policy students, you could imagine, running the continuum from doing nothing to doing something very, very different. And at the far end of that continuum, doing something very, very different was probably marked by proposals to do what's called Medicare for All or single-payer universal health care system, much like every other Western industrialized system has, where essentially the government, if it hasn't nationalized health care, which Britain has, is, in all the other Western countries, actually the payer for health care. Now, we have a system like that here in California, in the United States, called Medicare. We just reserve it for everybody who's 65 years and older. And we have another system for veterans. The VA administration is also a single-payer system as well. And while each of those systems has had its challenges, by and large, they have accomplished the goal set for them, which is to provide greater, more universal and reasonable access to care for those particular population goals. That was not what was enacted. What was enacted by Congress, the Affordable Care Act, was basically an idea that emerged from a conservative think tank, the Heritage Fund, which was a market-based approach to reform. So very different from a totally government-based approach, which would be single-payer, where basically the health insurers would be taken out of the equation and the government would be the payer to medical providers for care. The market-based approach, the Affordable Care Act, had a number of key ingredients in it which we have moved forward to implement. One key ingredient was we're trying to get everyone covered. So how do we do that? Well, we require that individuals get coverage, and we require employers with more than 50 employees get coverage as well. Why? The idea is pretty simple. It's to make sure that the risks associated with disease and illness get spread across a larger population, so that we're better able to pay for those risks, and that those risks and costs aren't disproportionately borne just by those that ultimately get sick. So you need to have everybody in. We do this currently in California and every other state in the nation with auto insurance. We mandate that people have auto insurance. We don't just leave it to them to get it. Why? Because we want to spread the risk associated with driving vehicles across a larger pool and make sure that everybody is sharing in trying to address that risk. The second piece of the ACA is the prohibition on pre-existing condition exclusions. What was this? Well, it used to be, before the Affordable Care Act was enacted, that health insurers could say to you, you're not going to get health insurance from me because you were sick once before. And they would do this routinely. And they would do it from a very sound economic rationale, which was they didn't want sick people to be buying their health insurance. They wanted well people to buy their health insurance. And they wanted people likely to stay well to buy their health insurance, so that they wouldn't have to pay out very much to help treat those people ultimately. So they adopted policies that essentially screened out people who had prior illnesses. The Affordable Care Act says, no, we're not going to allow that. No more can health insurers or HMOs prohibit you from being a member of their policy, from buying their health insurance HMO product due to a pre-existing condition. Big, big change. Third key tenet was online health insurance marketplaces called exchanges. And what these are simply are marketplaces that were supposed to function in each state, where individuals and small employers could go to purchase health insurance, where the benefits would meet a certain floor of benefits, so there'd be uniformity, and there'd be an architecture where individuals could compare products based on price and cost sharing. So there were requirements that there would be different levels of products that have different what are called actuarial values, and what that simply means is the share that the insurer pays versus the share you pay would be demarcated. And then you could do apples-to-apples comparisons across products at different price levels and have an understanding of what you're actually getting. Prior to this change, good luck trying to figure out what was in your health insurance policy, in your HMO policy, comparing benefits, comparing between different products, really, really hard to do. The notion of the online health insurance marketplaces was to systemize, standardize, but also provide a subsidy to individuals below certain income levels to help them afford the health insurance also. That subsidy is a premium subsidy. Technically, it's a tax credit, but it comes right off the top of the premium. And for a family of four, that makes, say, around $79,000 a year, you're eligible in California for a premium subsidy. It scales based on how low your income is. The lower your income, the more subsidy you get. The higher income, the less you get. And for families of four making less than $79,000, you're eligible for some level of premium subsidy. And the notion was that these would be online so that consumers could have easy access to them. Fourth tenet was expansion of coverage for the poor. The national program of health insurance for the poor is called Medicaid. Here in California, we call it Medi-Cal. And a key tenet of the Affordable Care Act was, for the first time, to allow single adult individuals to be eligible for Medicaid, or what we call Medi-Cal in California. Now, these are individuals that we see in all of our communities. Oftentimes, they're individuals that might have substance abuse issues. You might see them homeless. They're also working individuals. In fact, a large share of single poor adults are working, but still not able to make enough to be able to afford standard health insurance on the market. Prior to this change, to be eligible for Medicaid or Medi-Cal, you had to have kids, you had to be a senior, or you had to be disabled. Allowing single adults to be brought in was a way to expand coverage to more people, hopefully reduce cost shifting, and make sure that people got access to preventative care before they got really, really sick. So those are essentially the four tenets of the Affordable Care Act that were enacted by Congress and signed by President Obama into law. Now, what did we do in California? Well, in California, we went all in. Every component of the Affordable Care Act has been implemented here in California. Very different from what other states have done. In fact, quite a number of other states opted out of some elements of the Affordable Care Act because of the political controversy associated with it. And it turned out that something on the order of, I think, 34 states or so ended up not creating the online exchanges, and instead, all of their residents was thrown into a federal exchange, not California. We enacted every piece of the Affordable Care Act that we could, and there was actually bipartisan consensus around this. Governor Schwarzenegger was governor when the Democratic legislature put on his desk the bills to begin implementation of the Affordable Care Act, which was enacted at the federal level in 2009. In 2010, Governor Schwarzenegger signed into law the various state laws to begin implementation in California. Republican governor, Democratic legislature, bipartisan support. And a little history there. Governor Schwarzenegger actually tried to form, first emanated from the conservative think tank, the Heritage Fund. There were a number of Republican governors that picked it up. Mitt Romney of Massachusetts, who was successful in getting it enacted in Massachusetts, and then Governor Schwarzenegger tried to get it enacted in California. It ran aground in the state Senate because the state Senate wanted to see single payer, so it didn't happen here then. But we've had a long ramp towards takeoff on the Affordable Care Act, because effectively we've been working on it since 2005. And that's been critical, I think, to its success here in California. So what do? We expanded Medi-Cal. We took advantage of the opportunity to expand Medi-Cal to single adult individuals. That number is actually a little bit off. It should be 2.7 million. So we ended up expanding Medi-Cal and adding 2.7 million Californians to the Medi-Cal rolls. We also went forward and adopted all of the various market reforms I talked about a moment ago, including the prohibition on exclusions due to pre-existing conditions, eliminating lifetime and annual caps, providing certain preventative care for free, and also a very important one for some of you here, the provision of the Affordable Care Act that allows people to stay on their parents' health insurance or their guardian's health insurance until age 23. Huge deal. That actually has helped about 400,000 young people in California who otherwise would have found it very difficult to find health insurance. They're now able to stay on their parents' or guardians' health insurance as a result of that particular change. So this is just a short list. There's a much longer list of the various market reforms that we enacted in California, but we enacted every single one. Here's another important one: eliminating gender rating. Now, what health insurers used to do was they basically made it a pre-existing condition to be a woman. How did they do that? They charged women more than men for basically the same set of services. So one of the key tenets of the Affordable Care Act is to eliminate the ability of health insurers to charge women more than men, eliminating gender rating. So long list of reforms. We don't have enough time to go into all of them. And we also established an online marketplace or exchange, what we call Covered California, which is administered by a separately appointed board. I don't oversee it directly, but it administers our state exchange, which provides the premium assistance. And in 2014, they enrolled 1.1 million Californians in Covered California, about half of whom did not have health insurance previously. We just, the other day, ended the open enrollment period for 2015. 474,000 people signed up. You can't add those two numbers, though, because of the 1.1 million that were there in 2014, there's been some drop-off. So the net now is about 1.2 million in the 2015 market, those that enrolled 2014 and new people coming in 2014. So those are big numbers, and we were far more successful in enrollment than any other state and the federal government. You probably read about the disastrous rollout of the federal exchange, where they couldn't get their website working. Huge problems in enrollment. They finally got righted that ship, got that moving in the right direction. California, thankfully, we had some bumps in the road, but we did not have that sort of challenge. So, how has it worked? Well, first, I think it's important to note that across the United States, the rate of uninsured has dropped from 17.1% of our population to about 12.9%. About 11.4 million people have signed up in 2015 for the federal and state exchanges overall. California is obviously a big piece of that. In California, we basically reduced our uninsured rate from 22% to 11%. We went from roughly 7 million uninsured to about 3.2 million uninsured. There's about 3.4 million that are newly insured. And then this is just a short description of some of the immediate benefits that these newly insured Californians will have access to for the first time, and some numbers associated with that. So that, from an enrollment standpoint, is the progress that we've made. I think it's somewhat important to understand sort of the breakdown of sources of coverage for the previously uninsured. There was a Kaiser Family Foundation survey that looked at this very question, surveyed uninsured people in 2013, and then surveyed them again in 2014 to discern how many of them now had insurance and where they were getting insurance. And of those that were getting the insurance in 2014 in California for the first time, 25% reported that they were obtaining coverage through Medi-Cal. 9% of the previously uninsured enrolled through Covered California. So about a third of the 50% or so that got insurance, about a third got it through either Covered California or Medi-Cal. The remainder got it through an employer. Some just bought it on the individual market outside the exchange. So some good results in terms of coverage, definitely, both across the United States and in California. One challenge we've had in California, though, is to make sure that the enrollment numbers are representative of the broad diversity of California. And there we still have progress to make. African Americans and Latinos, for example, in 2014 were disproportionately overrepresented amongst the uninsured, but underrepresented amongst those that were signing up for Covered California. And so that continues to be an issue that we have to address collectively as leaders in California. We don't know the numbers yet for 2015, but there was a concerted effort to do marketing and outreach to all of California's diverse communities to try to get those numbers up in terms of signups from all of our diverse communities. So let me move quickly now to challenges that we face with regard to this reform. And it's by no means a perfect law. There are a lot of issues associated with it, some of which I've already alluded to, but specific ones that we face in California are several-fold. First, what's called network adequacy. What this refers to are the medical provider networks, the doctors, hospitals, chiropractors, nurses, clinics, etc., that are attached to the health insurance or HMO product. And what the health insurers and HMOs did in 2014 was, in order to try to reduce their costs, they began to reduce the numbers of doctors, nurses, and hospitals and clinics associated with their health insurance. This has been referred to as narrowing the networks. So in 2014, as the state's insurance regulator, I started getting complaints from consumers, families, about long wait times, long travel distances to see a doctor, and inaccurate medical provider lists. What's that about? So when you sign up for the health insurance, you're able to look at a list of the doctors that are associated with that health insurance to see if your doctor is a member of their network, or to see who the doctor might be who's a member of their network. It turned out many of those lists were inaccurate. People would sign up for health insurance thinking that their physician, their primary care physician, was a part of that health insurance network, get all signed up, start paying premium, go to the doctor, and the doctor would say, no, I'm not connected with that health insurance. In fact, I'm not even taking Covered California health insurance. Big problem with the inaccuracy of the medical provider list. Another big problem is surprise bills. So this is the phenomenon where you do everything humanly possible as an insured person to make sure that when you're going to go get your treatment, that the person treating you is within the network and the health insurance covers it. So I'll give you an example. Say you're going in, not any of you, you're too young, but for a knee replacement or a hip replacement. And so you do everything you can to make sure that all the surgeons and people involved at that hospital or that ambulatory surgical center where that's occurring are in the network of your health insurance. So your health insurance is going to cover it. You go in, they put you under, and one of the physicians invites one of his former med school buddies into the procedure to help. And that physician is not in the network. And so you leave, successful surgery, you're in rehab, you're walking again, and you get hit with a bill for tens of thousands of dollars from that physician, that surgeon who was there in the course of treatment, who was not in the network, and you knew nothing about it. Surprise bills, big problem. So what are the solutions to this problem? Well, one is to require the health insurers to increase the number of medical providers in their network. Another is to hold them accountable to have networks that provide reasonable access. And that's the job of the insurance regulators in the state of California, both my department and the Department of Managed Healthcare, which oversees HMO. So at my swearing in on January 5th, 2015, I issued an emergency regulation to do exactly that, to set new and higher standards on the health insurers that are under my purview with regard to having adequate medical provider networks, accurate lists, no surprise bills. My regulation requires that you be told as a patient before you go in to get the treatment if anybody is going to be in that course of treatment that's not a part of the medical provider network. And if they're not, if you're not told that, then you can't be charged the bill. So this whole issue of medical provider network adequacy with regard to private health insurance will continue to be, I think, a big challenge in 2015, 2016, 2017, and the years ahead. Now, another big problem that we have in California, and we're not unique on this one either, medical provider and network adequacy is a problem across the United States and a problem in California. Here, medical price transparency is a problem, and that's a problem across the United States as well. What am I referring to? Well, you can't find out the actual cost or price of a medical procedure to save your life right now in California. It's been likened to going to a department store putting a bag over your head, not one that you can see through, by the way, and then moving your cart through the department store and just picking things off the shelf, getting to the checkout line, giving the sales attendant your credit card, they swipe the credit card, and maybe when you get out in the food court, you take the bag off and you see what you bought and what it costs, if you're lucky. You cannot get price in medical procedures. Why is that? Because the various stakeholders in the system have a keen economic interest in withholding that information from you. It's in their economic advantage not to provide it to you. Why? Because the pricing is all over the map. Medical providers have different degrees of bargaining power in different markets. And in some cases, they're able to get good deals for themselves from health insurers, in other cases not. And even a given hospital, say within the Inland Empire, that has contracts with 5 or 6 health insurers, may be charging for a given medical procedure differently across those health insurers based on their respective bargaining power vis-a-vis that health insurer. Similarly, physicians' offices, physician groups, labs, there are huge differentials within the same geographic area. For a simple lab test associated with blood work, you can have an order of magnitude difference of thousands of dollars, even though they're within the same geographic area. So, huge disparities in pricing, huge inability to see what prices are, big problem with medical price transparency. And again, the hospitals, the physician groups, the health insurers, the HMOs, the pharmaceutical companies, nobody wants to share the information that they have about the pricing because it's not in their economic interest to do so. So the solution is we've got to figure out a way to make medical care pricing information and quality information public. And that's even more acute a need as we're moving into health insurance policies that have higher deductibles, higher co-payment, higher co-share requirements, which is exactly what we're moving into in the world of the Affordable Care Act. So there are caps in the Affordable Care Act for out-of-pocket costs, but those caps are pretty high. For an individual, $6,800, for a family, in the tens of thousands of dollars. So it matters to you how much it's going to cost to have a lab work or procedure done somewhere, because you're going to pay out of pocket before your health insurer kicks in for that stuff. You can't find that information. We got to figure out a way to do that. Now, what I'm trying to do to advance the goal of trying to make that information public is the Affordable Care Act had a grant opportunity in it. I've applied for grant funding from federal HHS, about $4 million, to try to set up what's called an all-claims, all-payer database, which would essentially be an online portal in its ideal vision where a consumer or business could go, look up the name of a doctor, and find out what that doctor charges for something. Or look up the name of a hospital, and find out what a hospital charges for a particular medical procedure. Here's the problem. Here's why my staff recommended I not apply for the grant. As a commissioner, this is a losing proposition. There's no way we're going to be able to accomplish this because nobody wants to share the information. I said, you know what? It's important. We've got to figure out a way to move the ball downfield, and if we fail, we're going to fail boldly. So we've got the grant money. We're setting up a data center. Now, one thing I've learned in government is you don't want to do IT in government. Government is littered with bad examples of IT projects. So we did an RFP. We got a great proposal from University of California, San Francisco. We partnered with them. They're creating a data center, and we're grabbing whatever public information we can to put in the data center. And this summer, we'll unveil this. It'll be online. And what you'll be able to get, and it's just a start, is in every geographic area of California, you'll be able to get the average price for 90 common medical procedures, the min and the max. So at least you have some reference pricing to compare to as you try to find out what it's going to cost at a particular medical provider. Our hope is if we build this thing, they'll come, and we'll get more of the stakeholders to provide their information. At some point, consumers are going to demand this, and the legislature may respond by mandating it. So we're trying to encourage all the stakeholders to see that it's in their economic interest to participate in this to get at this medical price issue. It's also important because without pricing, you can't have a real market. Think about it. If you don't know what the price of a good or service is, how can you have any kind of functioning market? It just doesn't work. And there's really no other good or service in California that you can't find the price out before you go in to get it than medical care. So that's a big issue. Okay, let's talk about pricing a little more. Third major challenge, health insurance price increases. Right now, there's no one in California that has the authority to reject excessive health insurance and HMO rate hikes. That comes as a surprise, perhaps. 35 other states have given their insurance commissioner that authority, but not California. I have this authority for car insurance, for home insurance, for all property and casualty insurance. Since 1988, California commissioners have had the rate regulatory authority for all of these other insurance product lines and have used it to good effect to save over $100 billion in rates for consumers since that time by using that authority. It's not wrecked the market. All those insurance companies are still here. You have the lizard company. You have the lady dressed in white company. You have that insurance college company. You have the people with the nice hands. They're all here. They're all making money. They're selling insurance. But they cannot gouge you because there's a regulator who has the authority to say, wait a minute, this is too much. You're allowed to make a reasonable return, but not so much that you're gouging people. But that authority does not exist for health insurance. I've been fighting to try to get that authority for 8 years now. When I served in the Assembly, I had 3 bills to give this authority to the Insurance Commissioner. As your newly elected Insurance Commissioner in 2010, I sponsored a 4th bill. All 4 bills died as a result of the opposition of the health insurance lobby in the legislature. So, last year, I worked with a consumer coalition to put a ballot measure in the ballot, Prop 45. Some of you may have seen the commercials. The commercials talked about this greedy politician from Sacramento who wanted to take over control of your health care. There was one commercial that actually had me in an OBGYN examining room. I was trying to figure out, like, where am I going to find time for that? You know, I mean, it's just one of me. I can't be in every exam room across the state of California. So the health insurers spent $58 million in misleading and deceptive advertising across the state of California to effectively persuade voters not to vote for Prop 45. The Consumer Coalition that I was a part of, we had about $2 million at most, and they just swamped their vote. So right now in California, unfortunately, I believe we're going to continue to see health insurance rate hikes over time. The health insurers pushed the pause button for about a year or so, but we'll keep seeing them because of some of the reasons I'm going to get into further detail about in a moment. But we don't have any authority here in California to do anything about it. Health insurance market consolidation, the 4th major challenge. We have a very consolidated health insurance market in California. We're not unique in that regard. In fact, every health insurance market across the United States is characterized by a high degree of consolidation. Why is that? Well, because to be a health insurer HMO, you got to be really big. You have to have a lot of infrastructure. You have to have a lot of capital to do it. There are significant natural barriers. Those of you that study economics, significant natural barriers to entry. These are really essentially monopolistic or oligopolistic markets by their very nature. So in California, just 3 health insurers control over 80% of the individual market. There's a little more competition in the small employer market, a little more competition in the large employer market, but the individual market, where a lot of our focus is with regard to getting uninsured and insured, 80% of that market is controlled by those top 3. And that results in monopoly or oligopolistic pricing downstream, which means that ultimately we are price takers and they are price setters. And that is a big, big challenge we face in California on a going forward basis. And why, going back to the other slide, I think this is a market that really is one where regulation is justified. I'm a big believer in free markets, and market competition is a way to allocate goods and services in most markets. When you have a market characterized like this one, by a high degree of concentration, by monopoly or oligopoly pricing, I think the appropriate policy response is some degree of regulation. Think about it. We do that for other markets where there are essential goods, big economies of scale, high infrastructure costs, water, electricity, natural gas. We have regulators to set the price for that because we don't want those markets to be markets where consumers and businesses are priced out of existence. Another big challenge we have, medical provider consolidation. So not only do we have a high degree of consolidation amongst health insurers and HMOs, but hospitals are buying hospitals are buying physician groups are buying physician groups, labs are being bought by hospitals. All of the different components of the medical provider universe are consolidating through a whole series of mergers and acquisitions. So that may be a good thing because potentially it might provide for better coordination of care. If you have more of these entities under single ownership, there can be more alignment with regard to the kind of work that they're doing. But it does also pose a problem in terms of the potential for monopoly pricing by the medical providers. And so in Northern California, for example, there's a very dominant hospital chain. And as a result, in Northern California, the price for just about every major hospital procedure in Northern California, there's a 50% surcharge in Northern California versus Southern California. Because there's less competition in Northern California in the hospital market, there's more consolidation, and that hospital system is able to command monopoly prices. So medical provider consolidation is an ongoing problem issue, again, one that I think warrants rate regulation, but that's not a policy response that we've been able to get enacted here in California. Fraud. So one of my responsibilities as a law enforcement agency is to investigate insurance crimes and fraud. And it turns out that the single highest dollar value type of fraud is medical provider fraud. If you look across all the different insurance products, auto insurance fraud, home insurance fraud, life insurance fraud, disability insurance fraud, workers' compensation fraud. The average suspected loss per open fraud case in the health insurance space is about $11 million per case. Any other insurance fraud where you have an open investigation, it's in the hundreds of thousands of dollars. So medical provider fraud is hugely expensive, and it can be very, very corrosive, involving a hospital CEO in Long Beach, a gentleman named Michael Drobot, who owned a hospital. And what this gentleman did was he set up a company which then purchased implants for spinal surgeries. And so what he did at his hospital was he purchased the implants from his company, and then he did spinal surgeries at his company for people that had legitimate back injuries that they had suffered at work. And then he charged workers' compensation insurers for the markup of the surgery and the markup of the spinal implants. And there was no reimbursement schedule in law at that point, so he could charge whatever he wanted to. So he decided he was making so much money, hand over fist, he decided to make it a volume business, and he started bribing physicians to refer patients to his hospital, which is illegal. You can't do that. And so we opened an investigation. It resulted in our uncovering $500 million of workers' compensation fraud. But it also had a tremendously corrosive effect on public policy generally, because, now I'm going to say alleged, Mr. Drobot has pled guilty to a number of federal counts, and he's now the principal witness against the gentleman I'm going to describe. I'm going to now say alleged because, while this has been alleged, this gentleman hasn't had his day in court yet. But evidence was discovered that indicated that Mr. Drobot was bribing a sitting state senator to get that state senator to prevent any legislation from passing that would set a reimbursement schedule for these surgeries. And that state senator happened to sit as the chair of the Senate Insurance Committee. We reached out to the FBI. They opened a parallel investigation. That investigation involved setting up a sting operation, because it turned out that that state senator also was sitting on the state's Film Tax Credit Commission. And so the FBI set up a false front movie production studio, basically an FBI agent and his or her assistant, and they ended up in communication with the state senator. And it's the allegations now in the federal indictment against the state senator are that the state senator took bribes associated with both preventing the passage of laws that would create a schedule for this sort of work comp insurance fraud, but also took bribes associated with the distribution of film tax credits. And so that state senator is now being prosecuted by the United States Attorney. That began as a workers' compensation insurance fraud case. So fraud's a big problem, and fraud can be corrosive of the overall public policy system. So what I've done to try to address that is established an enhanced anti-fraud program at the Department of Justice, using proceeds that I was able to obtain in a landmark settlement against a hospital system that was engaged in billing fraud. I directed those proceeds to set up a new unit within my department to go after medical provider fraud. Another challenge, Medi-Cal reimbursements too low. So a moment ago I told you we've signed up 2.7 million more people to Medi-Cal. That means that, I want to make sure I give you the right number, but something on the order of 11 million Californians now are on Medi-Cal. And one of our challenges is that the reimbursements paid by Medi-Cal for physicians that take Medi-Cal patients are too low. And as a result, there are very few physicians that want to take Medi-Cal patients. So that's a big problem. And the solution would be for the legislature to increase Medi-Cal reimbursement, something that I've been urging the legislature and the governor to do. Another big challenge is just overall medical provider shortages. I talked a little bit about how the health insurers and the HMOs have reduced their medical provider networks, but we also face, looking out over a significant time horizon, a potential shortage of primary care physicians. And that shortage is more acute in some areas than others. In the Inland Empire, for example, it is projected that there'll be greater shortages of medical providers than in other areas of California. So it's estimated that we need about 8,250 primary care doctors in the next 15 years. So how are we going to get it? Well, more medical schools. I was proud to support the conversion of UC Riverside Medical School from a 2-year to a 4-year school, and I had a chance to come down about 3 years ago and meet the dean and understand the vision that the university had for that school. More residencies. It turns out that where medical students do their residency is oftentimes the place that they set up their medical practice. So if we get more residencies in the Inland Empire, that might mean more physicians would serve here as well, and in other underserved areas of California. There's actually legislation that State Senator Roth, who represents this area, is introducing to try to increase state funding for graduate medical education for that. And then loan forgiveness. There are a variety of different strategies to try to target, to reduce the impact on medical students and medical residents, to try to get them to move into primary care in ways that they're often not economically incentivized to do because they can make so much more money as a specialist. Okay, finally, one other problem with the Affordable Care Act is it leaves many Californians uncovered. There's nothing in the Affordable Care Act for undocumented persons, 0. And there's nothing in Medicaid for undocumented persons, 0. And so we have roughly, of our original 7 million uninsured, about 2 million are undocumented residents of California. They're not eligible for coverage under the Affordable Care Act or Medi-Cal. There is a Senate bill that's been introduced this year that would extend coverage to undocumented persons, but there will be no federal assistance associated with that because the Federal Affordable Care Act expressly says none of the federal dollars can go to help undocumented persons. And there will be significant state costs associated with doing that. But that is a problem because people are still getting care. Remember, as I told you earlier, they're just getting it at the most disadvantageous time for them because they wait very, very long for treatment, and at the most expensive time for us when they go into the hospital. Conclusion. So, major benefits that healthcare reform has brought us here across the United States and in California, but still major challenges with regard to costs and access to care. A lot of work for all of us to do. A lot of work for you to do as future leaders of California. Believe me, this work will still be there by the time you're in leadership positions, I have no doubt. And one of the reasons it'll still be there is because we have a total lack of political consensus about this reform. It continues to be a huge fight. Even though it began as a market-based reform out of a conservative think tank, it's been framed as socialism. And as a consequence, it's become a wedge issue between conservatives and liberals. And as a consequence, there's very little talking between the two and a lot of arguing and a great inability to look for common sense solutions that would bridge those divides. It also makes this reform very unstable. In about a week or so, we're going to potentially hear from the United States Supreme Court, at least I believe there's oral argument, on a case that raises the question of whether the federal exchange, which operates, I believe, in about 34 states, can actually provide taxpayer premium subsidies to all the people in those states. It's possible the Supreme Court will say no, in which case that component of the reform goes away. California, I think, will continue down the path of reform. We're a big enough state, we have big enough resources, we're very dedicated to putting this into place, we've made a lot of investments, and so I think even if the wheels fall off the wagon at the federal level, although it will be hard for us to go it alone, I think we'll continue to try to work towards more reform, that get more people covered, provide greater access to care, and make sure that people needs are being met based on their income eligibility. So that's a fast run through, and I would be delighted to take questions at this point.
Hi, so one of the major
Could you
challenges...
speak up so that people in the back can hear too?
Hi, so one of the major challenges that I have encountered personally is my parents who were with Medi-Cal originally, but after the passing of the Affordable Care Act, their premium rose to, or share of cost rose to $2,500 per month, which was completely unaffordable. Yet when they went to the Affordable Care Act and tried to get healthcare from them, they said it was impossible. So now they're kind of stuck in a place where they're uninsured, and apparently 8,000 other individuals in the state of California have that. What steps should I take as an individual to circumscribe that?
So I think what you're talking about is the family glitch. There are a number of glitches in the Affordable Care Act, don't get me wrong, not a perfect app. One glitch is a glitch that basically requires employers to provide you with health insurance and sets a standard for affordability of that health insurance. But that standard of affordability is based on just the main wage earner, not all of the family members being included in that health insurance. So even though technically the employer is meeting the mandate, they're not really providing a product that ultimately is affordable. But because they're meeting the mandate, you then can't go into the exchange as an individual and purchase the health insurance. The only hope for trying to fix that glitch is federal legislation. And I don't want to be too pessimistic, but right now Congress is totally in gridlock about any changes to the Affordable Care Act. You have Republicans who want to abolish it, and you have Democrats who would like to make changes but are fearful about suggesting changes because any suggested change suggests it's not working well, and they're worried that Republicans will grab that and use it to their disadvantage. So I don't have an immediate solution for you, unfortunately.
Not a question. Could you just move the water bottle?
I'm sorry.
Sorry, any other questions? Yes, Kevin.
So I was interested in your slide about pricing transparency, and I'm sure in your grad school days you read Kenneth Arrow's paper on the welfare economics of healthcare, where he argued essentially that it's not possible to have a market for healthcare because of the information asymmetries between physicians and patients. And so what that looks like is a patient, if a physician says, oh, you need to go to this facility and get this treatment, the patient really can't say, no, I'm going to go to this other facility and get this other treatment because it's cheaper. And it just doesn't really, that doesn't really work. And so while I agree that having prices helps, I mean, it's better to have prices than not have prices.
Yes.
But it doesn't solve that problem. And so when I was, and so I hadn't thought about this until I saw your slide, but I'm wondering if you could go, if you have UCSF on board and you've got, there are a lot of smart people there, that if you could go a step further and maybe think about if there's a way to solve it by linking that your database with an app that would connect with electronic health records, so that when there's an order put in through the health record, it's somehow, I mean, I can't, I'm not going to solve Kenneth Arrow's problem sitting here right now, but you can imagine there'd be a way to have it so that when the physician puts in the order, it might then connect to that menu of not all of the facilities with all of the interventions, but just the ones that actually would do what the doctor actually wanted.
Right.
And then, but then without the physician knowing about the pricing, right? So then the patient gets to see what the prices look like and then choose among those. And then it would be like all within their app, on their phone, so they could just say, I've got these 3 different facilities to choose from, something like that. And just maybe if there's some kind of IT way to maybe prove Kenneth Arrow was wrong.
Well, I mean, I think that, I don't remember reading the paper, but I think that the general point is legitimate, which is that there is a great asymmetry between the relative position of the physician and the patient. But I think there are some things we can do incrementally to improve it. So not having any price information is not a good response to that.
But I think some doctors would say having the prices might actually make things worse.
Well, they do. And that's why what we're trying to do is called pricing quality. But so what the doctors argue, what they'll say is, well, we don't want to provide this information because patients will make bad decisions based on price. I think people are smarter than that. I really do. And I think that some of that argument is a little bit self-serving because physician groups don't want to share the information. Now, there is some merit to it. It's possible if you were totally driven by price, you could make bad decisions about where you go. But we're so far away from anything close to that. You have no information right now. I think your idea is a really good one. I think some health insurers actually, for their members, are providing tools where if you're a member of that health insurer, you can get a list of a more accurate list, and hopefully the ones that they are providing when you sign up, of medical providers within your region that will provide a particular service, and they're providing some price information to their members too. But they won't share it outside of that system. And so it makes it very difficult then for members, for people who are not in that health insurance network. And it also makes it very difficult in terms of your initial decision about what health insurer to join. So I think this is a good idea. The other thing that we've directed UCSF to do is to try to include a crowdsourcing component to the data center. There actually is a public radio station in Northern California that's done this. A Bay Area public radio station has a website, an online portal where people can upload their explanation of benefits and charges associated with medical care, and they're trying to create a database too. I think it's a great idea. I think that the subscription level to it is really low right now. There's not enough data in it to be meaningful, but I've asked that UCSF include that, because you can see a path where as consumers become more price conscious, as they're forced into these higher deductible, higher copayment, high co-share plans, they're going to be thinking a lot more about price, and maybe they'll be motivated to include that information of others. Then I would just also challenge you, if you can come up with some psychic reward, like killing a bird or crushing some candy, that would encourage people to load their information up. And I'm talking about these games, right? Candy Crush, Angry Birds. Okay, that's my old guy allusion to some game that I actually know very little about. But anyways, you get the idea. People play that stuff all the time, right? Because they like the little hearts or the little candies or the little, they killed a bunch of birds. So if we could figure out, if you guys, not me, but you guys could figure out some way to create some psychic reward to get people to crowdsource their medical information, let me know. But yeah, I take the general point. I think it's a good idea.
But do you think there is, actually, we were talking about this over lunch, and sharing this information, there's sort of a public shaming dimension of sharing information. If a provider sees that he is charging 20 times the average price in his geographical area for exactly the same procedure, at some point, he's going to be held accountable.
That's like the toxic release inventory for polluters. When they see that they're the highest polluter in their area, there's kind of incentives to.
And I think last year the New York Times ran a series of articles where they actually, these were front page New York Times articles where they actually said, we did a survey of what providers in the New York metropolitan area charge for a colonoscopy, and the factor by which the price of a colonoscopy varied in the New York area alone was like 50 to 1.
Yeah.
I mean, there were places that charged $800 and there were places that charged $15,000.
And there have been studies that show, to your other sub-point, that there's no correlation between quality and price. Absolutely none. So the argument of the physicians about, people will all run to the lower cost provider. I mean, there have been studies that indicate that pricing disparity cannot be explained by higher quality. So you can't have a market-based approach to providing health care. If we're going to have a market-based approach, and that's what we've got, and we're going to have it for some time because I think we're a long way away from building a political consensus around single payer, notwithstanding Medicare and the Veterans Administration system. If you're going to have a market-based approach, you have to have some semblance of a market. You have to have meaningful real-time price information. Without it, you're lost, which is exactly where we are right now.
Questions? Yes, Rachel.
Yes, I have a question. You touched on it earlier in your slides about the health disparities in Black and Brown communities in regards to infant mortality rates and mortality rates in the long term. And so I'm glad you brought it up because that's a really big interest of mine. And in regards to health insurance, so we don't have a lot of great preventative care when it comes to those communities. And so, part of, I think, health insurance in the long term should be, when we're revising all of these things, is to include partnerships with planning communities and people that are in specific cities to plan accordingly to the health disparities in that region. So it's not so much of, that kind of would go more toward like a social approach more than a market approach, because you'd have to have a partnership, and then that would get into the monopolies and the oligarchies in medical care. But I think that would be really important, and plus if we're going to be increasing our spending in regards to the GDP of health insurance and healthcare, that would be a really wise way to go about it. And of course you'd get a lot of combat from the more conservative viewpoints on partnering with people like that. But I think it's so important, and people are not really educated that does occur in those communities. And so I think that would be something to.
So your question is that how can insurance help narrow the disparities?
Yeah, and how can we partner in planning to fix those huge problems, because it's major problems.
So health insurance and health care delivery systems are just a piece of the puzzle. There are all sorts of ingredients or causal factors as to why people are not healthy and why particular communities have higher incidences of poor health outcomes as compared to others. So So yes, taking a more holistic approach makes sense, and that includes having a robust safety net for things like income supports, early childhood education, job training, programs that help people if they've had an encounter with the criminal justice system to change their behavior. I mean, there's a whole panoply of programs. There is, but where health insurance can play a role, and where we are, incidents of, or the percentage of those who are uninsured, who are either Latino or African American, is disproportionate to the percentage of those communities in the overall population. So there's a higher percentage of the uninsured. Those that are Latino, those that are African American, they are disproportionately represented amongst the uninsured as opposed to the rest of the population. So one way is to try to just get more people covered, and to the extent that there are individuals or families within those communities who are poor. I'm not saying there's a one-for-one relationship there. Obviously, there's not. But expanding Medi-Cal to 2.7 million people brings a lot of people in, and to the extent that you have a significant number of Latino and African American households or individuals that fall into the category of single adult individuals who are poor, we get them that way. The other thing is, by trying to do a better job within Covered California in signing individuals up for private health insurance with or without the subsidy. And there, the 2014 enrollment figures, again, were underrepresented in terms of Latino and African American households. And so in 2014, Covered California put a lot of money into trying to do more partnering with community-based organizations, more direct advertising, more communication through various media outlets that are received by various communities to try to increase the sign-up. And the hope is that will work. And then what that means is if people have health insurance, then they can have access to preventative care at lower costs, or some level of preventative care, which may then help them downstream to avoid things like obesity, diabetes, heart disease, some of the chronic diseases, the distribution of which is regrettably more concentrated within certain of these communities. So that's the health insurance piece. On the medical provider front, huge problem because of bad distribution of medical providers. So yes, looking for ways to try to make sure that there's reasonable access in all communities. And the emergency regulation that I issued seeks to do that by placing higher standards on the health insurers so that regardless of what community you're in California, you're supposed to be able to have access. If you don't, then I can mete out sanctions to the health insurer. So those are those pieces, but there's a lot more that needs to be done in a holistic fashion.
Yeah.
Absolutely. Yeah, great point.
We have time for one last question.
Hi, thank you so much for your presentation. There's so much work to do. I have a question about pre-existing conditions. I think that it's great that the ACA put in a clause on, having insurance accept people with pre-existing conditions, but I've been reading more and more about situations in which the insurance companies are still discriminating against people who are sick by sort of putting co-pays in the top tier
Yes.
for medications such as HIV. And so I was wondering, as a consumer protection agency as well, how
Right.
are you dealing with this sort of situation?
It's a great question. And actually, I dropped a slide. But one of the other challenges we face is exactly that, where health insurers and HMOs are contending with new state-of-the-art higher priced pharmaceuticals, like the new drug for hepatitis C, for example. And what they're doing is they're taking those drugs and they're creating pricing tiers. And they're putting the really expensive drugs in the top tier where they have a much bigger deductible, much bigger co-payment, and much bigger cost sharing, as opposed to distributing those drugs across tiers so that people have some reasonable access to those drugs. Federal HHS has issued a guidance that says that if all or most of the drugs associated with a particular disease or illness are put in the top tier, that's discriminatory. Because you're discriminating against the people that have that illness. So if you have hepatitis C and all of the drugs associated with trying to treat or cure what you have are put in the top tier, federal HHS said that's discriminatory. I agree. As a state's insurance commissioner, I take the position, I agree. Not everybody in California leadership positions agrees, but I agree. And so what I am doing is insisting with regard to the health insurance policies that are under my purview that not occur. I'm also involved in a major debate with Covered California, which I don't directly regulate. I regulate some of the products sold in it, but I don't regulate Covered California. They have their own separate board. They have set their own standard benefit design for health insurance and HMO products sold in Covered California, and they have allowed specialty tiering, at least tentatively. And I have said, no, you can't do that. You can't allow the health insurers and HMOs who are selling into Covered California to take all or most of the drugs associated with particular illnesses or disease, like hepatitis C, and put it in the top tier. You can't do that. So we're involved right now in a very robust dialogue with Covered California about that. I would urge you to write to them if you have a concern about this, and write quickly, because they're going to be making a decision in the next couple of weeks. We're hopeful, and we're making progress, and we're hopeful that they will relent. What happened was initially they weren't doing the specialty tiering, then the HMO lobbyists descended on them, then they started doing the specialty tiering, now the insurance commissioners descended on them. So, but patient groups have as well, and so I think now is the moment, if you care about this issue, to let them know. And that will be a sort of a watershed event because of the significance they have in the overall individual market. So, great question. And that opens the door to another issue, which was on the card that I dropped, which is other cost drivers in the system, right? So I've gone through a bunch, but just underlying costs of medical care delivery, and let's just pick one, pharmaceuticals, for example, are a major driver. And so, you know, why is that compared to other countries? Well, we've done a couple of interesting things. Number one, when the Medicare Part D prescription drug benefit was created in the Bush administration, the President and Congress decided not to allow Medicare to use its bargaining power vis-a-vis the pharmaceutical companies to get better prices for the very prescriptions that are made available to Americans who are older than 65 years of age to the Medicare Part D prescription drug benefit. So essentially you have this tremendous buying power of the federal government that's been completely neutered in terms of trying to get better prices for the Medicare system. So people complain about, you know, Medicare costs and unfunded liability for Medicare, but Medicare has one hand tied behind its back. One. Two, you know, we have very protective intellectual property regime in the United States that is good from the standpoint of encouraging research and development. We do some of the best research and development in the world here. But every other country is riding on our coattails because they don't have the same duration of patent protections. And if you look at, do apples-to-apples comparisons of particular drugs sold here and their opposite number in just about any other country, dramatically less costly in those other countries. Why? Because we protect for a longer time the intellectual property, the patent, the trademark, whatever it is, associated with these new blockbuster drugs. And we also allow knockoffs. So now you have what are called biosimilars, where if there's a biologic drug that's been created and you have a patent for some duration of time, if you modify a molecule or two and have a biosimilar, you can potentially extend that patent for another 7 years and have essentially monopoly or oligopoly pricing. So you know, that's a huge debate that is ongoing. On one side you have people who argue, wait a minute, but if we got rid of those intellectual property protections, we lose all that research and investment and innovation. There are others who argue we protect it too much. There needs to be some input. The other thing we do that's uniquely American, and we are uniquely American, is I think we're the only Western industrialized nation, we may be the only nation, which allows direct advertising to consumers with regard to pharmaceuticals. Nobody else does that. Nobody else does it. So I pick up a magazine, and I read something about something I didn't even know I had. And they want to sell me a drug. So I'm going to go to my doctor and say, I want this, you know. Nobody else does it. And that's also been cited as a reason why our pharmaceutical
The
prices.
doctor often, to get rid of you, he sort of says, okay, I'll just.
No, that's
prescribe
right.
you."
And so you're the consumer, and there's an example where, you know, consumer demand is actually having an interesting effect, because your consumers are demanding this stuff that you're seeing on TV or magazine or wherever, and the doctor says, okay, you know, I'm not going to fight. You've been a great audience. I'm glad you're studying public policy. If you're not, you should. Know this, public policy needs to do good things. We need more sharp, exciting, talented committee people like yourselves to be leaders in California, and I hope that whatever your path is, you'll engage. That's what we need. We need engagement. Regardless of your political views, your philosophy, whatever it is, we need engagement. So please get engaged. Thanks a lot.